We'll talk a lot about millennials. Who is millennials out there? Oh God, I feel your pain. I have 3 of them, but you are a millennial. Yeah. So how do you get them off your cell phone plan is the first thing I'd like to know. My middle daughter in Denver is an executive with DaVita, and she just got a promotion. I think she's a VP now for IT. Between her and her husband, I know they make more money than me, and I'm still paying their cell phone bill. It's a plot of Verizon and AT&T to make it so difficult you can never get them off. But anyways, I'm going to, very few slides, I'm going to tell a few stories and just kind of guide you through where I see the evolution of care, particularly primary care, is going. Raise your hand if you're a primary care physician. So for you folks, none of this will be a surprise. It's a major change in where healthcare is going. I actually am a dinosaur who's trying not to be a dinosaur. So that was me over there. I did house calls when I first started in practice, did primary care for 25 years. I can tell you, my wife always asked me at these events where people bring their food, why I never eat the food at the potlucks, because I did house calls and saw what the kitchens looked like. So I never would eat food from my patients or at potlucks. That's what I learned from doing house calls. But most of my career, 25 years, is really here in this second box. Is family physician, including 6 years in a small primary care practice. 6 years of my career, actually, I worked on Navajo Reservation in Shiprock, New Mexico, which really informed the rest of my career, the beginning of my career, and then I went back from 2009 to 2011. And they were doing population health before anybody even coined the term, and learned a lot about primary care in that setting. But really, I had 3,500 patients in a panel, and so if you guys are doing primary care, you know what that is. That is a lot of pain and a lot of work. And I can tell you that I saw a fascinating study recently that it looked at, if you have a panel of 2,000 patients, if you were able to do and hit the quality mark for the chronic disease, which is about 50% of your time, the preventive, which should be about 30 to 40% of your time, and then the acute episodic care. So for a panel of 2,000 patients, if you are doing good primary care, it will take you 14 hours a day. So the historic model does not work, doesn't work. I would see patients, around in the hospital, 7 a.m., I'd finish around 6, and then when the EMR came, didn't help me at all. Basically, it was more notes at home, as we all felt that pain. Epic, I was through 3 Epic implementations at different systems I worked at. Didn't help me at all. It just created more work. But I can tell you is that it is a really difficult job, and the model's unsustainable. We need to bring in other providers, pharmacists, nurse practitioners, and we've got to figure this out because the current system doesn't work, and we see this in just the match rate in primary care. It's going down because it's such difficult work. But that's the world that I spend most of my time in healthcare in. And then from there, I actually took leadership roles as a chief medical officer for a large multi-specialty group in Boston, and then 2 years as a chief medical officer in an integrated delivery network, which was fascinating because it's not only did you lead physicians, but you dealt with your hospital administrators who really talked about population health, but really didn't want to do that because 90% of the revenue still came fee for service. It was all about volume still, but I learned a lot in that time. And then I went to Walgreens. So I move over to here to the third box. Is my Walgreens jobs was interesting too. I oversaw their 500 retail clinics, which we transitioned many of those to health systems. I also was involved with their strategy of creating a healthcare neighborhood in the last 2 years, where we brought in primary care, lab services, hearing, vision, trying to bring healthcare into the neighborhood. And then around June, after 5 years, I left to go in this world. It wasn't that I had a compulsion to move to San Francisco to pay the highest rent in the country, or to wear skinny jeans, which I actually do now because I have to look young, or Allbirds, right? When we get Allbirds, well, you have to wear those in my office, or report to a 31-year-old CEO. He's a great guy, but he's younger than my son. But it was really about what I see as the next iteration of primary care, which is really telemedicine, but really unique aspects of telemedicine, the company I work as a CMO with now, it's a lot of it's asynchronous and a lot of it is actually delivering the prescriptions to patients. And it actually resonates very well with Millennials, of which I have 3. So when I was reached out for this job, I had never heard of the company. I said to my 3 kids, have you heard of it? They said, oh yeah, you should interview there, Dad. And they told me not to wear a suit, coat, tie. They said, jeans, white shirt, and your Allbirds, which they gave me for Christmas. I never wore until I went on the interview here. And at the end of the interview with my CEO, he looked under the table, he goes, hey, you got those Allbirds, those are really comfortable, aren't they? And I said, yeah, I love Allbirds. So it's no lie. So when I left the office, it was a beautiful day in San Francisco, left, and I texted my kids, 3 thumbs up to all my kids, and I said, you were right. But, so here I am. So let's get to the body of what I'm talking about. Really, what do consumers want today? I got to change this to 2020 because it hasn't changed this year. This is what we learned, what I learned in primary care, but we really learned in Walgreens, which is a very consumer-facing company. They want access and they want price transparency. If you come away with 2 things from this talk, remember access and price transparency, and I'll tell you why this is so critically important. In terms of access, we have a current and worsening primary care shortage. Several studies have shown by 2030 we're going to be 50,000 primary care docs short. I've even seen estimates twice that. So we don't have enough primary care providers. We have an increasing incidence, prevalence of chronic disease, and as I said before, the current model does not work. Nationally, it takes 29 days to see a primary care physician. I was speaking in Boston about 6 weeks ago and on a panel, and the person speaking before me was a CEO of a major health system there, surrounded by these towers, right? Beth Israel, Deaconess, Partners, BU, Tufts. In Boston, I looked it up before my presentation, 110 days to get a primary care physician. How can that be? Think of all the money that's been invested in healthcare in Boston. And looking out the window at all those towers, you can't see a primary care physician. So that is a major issue. And then price transparency, and I'll talk to you about price transparency. So, consumers are taking charge. In my day, it was, when I was practicing, I worked from 7 a.m. to 5 p.m. You had an answering service, and you prayed your patients didn't call you, and they were very, very considerate. They often did not. And then on weekends, you did not want them to call you. And then Monday morning, it was a disaster because they were sucking it up all weekend, and then they jammed the phone lines or just showed up at your office Monday morning. So the patients really followed the rules. The patients will no longer be patients, is what I say. They want 24/7 access on their schedule and not yours. So what we're looking at now is more and more folks are searching the internet for answers. They're going to apps. And this whole phenomenon about high deductible health plans has really changed the finance parameters and rules. 91% of folks want better price transparency. And why is that? Is because the average consumer on a high deductible health plan, 80% of them do not reach the deductible. 80% do not reach the deductible. So essentially they're paying for catastrophic insurance and they're paying out of pocket. And so they're very interested in what they're getting and how much they're paying. And finally, patients are going to change. They're going to change their providers for suboptimal experience, and they want better access and they want to know what they're paying for. So when I speak, and I work particularly at Walgreens with a lot of health systems, I was always asked that question, what do we need to do to be better? It's really, consumers want frictionless transactions. They don't want hassle, but they want multimodal access. They just don't want traditional primary care or, that wait till after the weekend, or you must get seen within 8 to 5 type hours. They want access on their own schedule. They want high reliability, and that is the quality imperative. In the prior talk, quality is really important. They assume that they're going to get a high reliability operating model based on quality. They want to be competitive on price, and they want more than a transactional relationship. So again, the high deductible health plan conundrum. The average annual out-of-pocket cost per patient rose 230% between 2006 and 2015. So folks are paying more from the employers for health, and they're paying more out of pocket. And this increased shifting of financial risk from the health insurance company, from the employer to patients. And the deductible and total cost out of pocket has been going up, as we talked about. So you have a totally different dynamic. And when we look at how are they going to access care, you need multimodal access. So the retail clinics, it's a really good low acuity model, about 30 diagnoses, high quality, usually with advanced practitioners. Primary care, I'm a primary care physician, so valuable but hard to access. Urgent care, I think, really has arisen. I think there's 10,000 of them now around the country because of the challenge of the next one to the right, which is emergency medicine, where the costs in the ED has gone up 170% over the last 10 years, and the payers are screaming bloody murder about it because it's not that the intensity of care has gone up, the price has gone up. And then telehealth, and this is the world that I am in today, and I think there's a role for each one of these access points, but particularly when it comes to low acuity, convenient care, is there definitely a role for telehealth. And why is that? It reduces the need for in-person visits, particularly asynchronous, which is the basis for what a lot of my company does. It's very convenient. And when folks who do telehealth, they say, do you like the face-to-face video versus answering questions, having a chat with the physician, getting information back? They like the asynchronous model better. Many of them are not comfortable with having even a video interview with someone they don't know, but they do love asynchronous. Asynchronous is pretty frictionless. The consumer can access it 24/7. They don't need to set up an appointment. And then for the provider, they can do that visit on their time. They just pick the visits out of a queue. And it does address shortfall in physicians. Definitely telehealth can do that, particularly in rural areas. I was on a call with one of the organizational leaders for a rural health association, and this is an acute challenge with hospitals closing in rural areas and lack of providers. How are folks in these areas are going to get care? And then the price transparency and convenience we already talked about. So I want to talk a little bit about millennials. Again, I know I'm obsessed with it because I live with 3 of them, or they live on their own, thank God. And they're married, and they're employed, and they all have health insurance, so I'm good. But really, why am I really interested in millennials? It's a big segment of the population we serve at the company I'm in today. They love what we have to offer. They love direct-to-consumer care. But they have major health issues that are really have been unrecognized. So a really interesting study, and I can provide the reference, from Blue Cross Blue Shield and Moody's, came out in the late fall. It looked at millennials, and what they realized in the study is that there is a significant and growing chronic disease burden in the millennial population. And if it goes unaddressed, there's going to be a 40% increase in mortality in that generation versus prior generations, 40%, and a 30% higher cost. What type of things are we looking at? Obesity, hypertension, hyperlipidemia, diabetes, and the big one coming down the track, depression and anxiety. So there is a major issue with health with millennials, and millennials do not access care in the traditional way that I access care. I ask my 3 millennials, do you need a primary care doc? Don't worry about it, Dad. I'll go to retail clinics, go online, I'll go on telehealth. They don't feel compelled to get a primary care physician. Their world is, they've grown up in this technology world. They want rapid delivery and convenience. That's the norm. That's table stakes for them. They have high expectations about efficiency and service. At the same time, they want to do a lot of it online. They prefer self-diagnosis. They have no personal relationship with physician. We found this in our own customers that we serve, that we think about 50% don't even have a primary care physician. They don't schedule preventive physician visits. I said to my 3 millennials, you know, as they approach the mid-30s, going into the 40s, you got to see a primary care. Other than my daughter who has an OBGYN, they don't. And 70%, particularly if it entails getting a prescription, they don't want to be hanging out at a Walgreens or CVS or Rite Aid. They want that prescription delivered to them, and they want that online visit. So that is the real challenge I think we're looking at today, is price transparency, access, and how are we going to deliver it, and how do we deliver it in non-traditional norms, because this generation, which has increased chronic diseases, is not buying into the traditional system. I think the one thing I will end with, though, is we build these models, quality has to be table stakes. And so I have 3 final slides that I won't go through, but basically a driver for me coming in and taking over this direct-to-consumer company in terms of the chief medical officer role was start with quality. And so we have a full-time nurse practitioner who reviews all the outliers in terms of charts and encounters that get referred too much, too little, any complaints. We've basically, since in the last 6 months, reviewed over 3,000 encounters. 10% of all encounters are reviewed. I know who the high-performing physicians are in terms of quality. I know the ones that need more coaching. We do educational videos for them, and they have to answer questions on each disease condition we treat. It's basically you have to focus on quality in the telehealth world. And I feel comfortable saying in what we've created is the highest quality care organization of any physician group that I've led, but it requires constant monitoring and investment in quality. And so that's my other take-home messages. Telemedicine, yes, there's a need for it, but you have to have the quality built into it. So that's just my perspective on where healthcare is going, particularly in primary care. Thanks.